So it's great to be here to give you an update on the situation in Canada. I want to extend thanks to Peter, who actually facilitated the fact that we're now having a Canadian panel on the conference. The original international pieces, I think, were limited to Jamaica and Uruguay. There's still a bit of a tendency in the US to ignore the neighbor to the north at times, to see it as the 51st state. But we really exist, and now I know our role. We produce dirt that the Americans come to clean up after us. So that's a new definition of the Canadian identity that we should keep in mind. Cannabis legalization in Canada. I'm going to give an update, a little bit about context and some key issues to put things a little bit into perspective, and then details will be followed by Brian and Linda with comments from Peter and probably Donald as well. So a little bit of context. Cannabis prohibited in Canada for almost a century, federally prohibited by criminal law. We had major controversy in the 60s, similar to the US. Over the last 50 years or so, numerous policy and law reform initiatives and proposals to move away from prohibition. None of them translated into any tangible policy change until maybe the near future, and we'll go into those details. We have very high use rates of cannabis in Canada, among supposedly the highest in the world, between 11 and 14% of adults, but very high use rates, up to 30% among adolescents and young adults. So prevalence is high. As Donald says, cannabis is controlled by federal law on the federal level. We have active prohibition with quite a bit of enforcement, focusing primarily on users and simple possession, but enforcement and justice outcomes are highly erratic and inconsistent. The one disclaimer that should be made right here, the details will come later, is that within this federal system of categorical criminalization, we have a medical marijuana program that's existed for about 15 years now that basically constitutes an extensive shield against criminalization under an umbrella of the medical marijuana program. We'll hear details about that in detail later, but it has major implications about how to go forward and implement details of legalization as we go forward. This just illustrates a little bit the trends in criminal law enforcement. Criminal arrests for marijuana actually have been going up over the last 20 years. It's definitely the #1 drug in terms of drug law enforcement. We also recently did some studies about the actual public health burden of cannabis in the Canadian population. Probably the most important detail here is that we have a sizable number of accidents and accident-related injuries and deaths where cannabis is a factor, which is quite relevant from a public health perspective, in addition to fairly large numbers of people who are showing up for treatment and other health outcomes, but accidents are definitely a big issue from a public health perspective. Public opinion, the important story here is that over the last 25 years, public opinion support for policy change has been consistently mounting. As of recently, we had about 2/3 of the population who were in support of prohibition policy reform, although that support has been divided between people who are in favor of decriminalization and legalization, with all the confusion that sort of exists around those concepts. Very, very strong mounting support for policy reform in the population, as you can see from the data. Now, a couple of things that happened recently. In 2014, my institution, the Center for Addiction and Mental Health, and one of the things that's notable there's many things notable about the institution, but the key thing that's notable is that this is a psychiatric hospital, the largest psychiatric hospital in the country, actually put forward a formal policy recommendation for legalization with strict regulation, basically making the argument that if we really want to regulate and govern cannabis in a public health framework, we need to make it a legal product. Only then can it be regulated, but things should be strictly regulated with the objective of public health. And that implied a number of things, including government-controlled monopoly, no commercialization, no advertising, strict access regulations, all under the umbrella of a public health approach. This was in 2014. It's quite a controversial recommendation. This was at a time when it was not politically safe and opportune to say that. Stirred up quite a bit of debate, but quite favorable. But in many ways also broke the ice on the discussion, if you will, for legalization as a public health-oriented policy reform. And then this happened. Now this is our political Superman, as you know. He's an accomplished stripper, he's a boxer, he knows quantum physics, if you've seen the media recently, and he's also a full-blown feminist. So I don't know if it gets any more perfect for a politician. The important thing for policy change, of course, is that the Liberals, quite early on in the election campaign, put legalization explicitly on the electoral platform. At the beginning, I think a lot of people thought that that was not a very smart move. But then, as it turned out, along with a number of other things, it actually worked in their favor and basically conveyed the Liberal platform, the Liberal Party, as really appealing more openly, more progressively to the electorate. And but this was an explicit campaign promise, which obviously was successful in the sense that the Liberals got elected in October 2015, and this element was part of the many promises they had made. And therefore legalization became official policy of the incoming government.
Is that an actual ad?
Pardon me?
Is that an actual ad?
The left part is one picture, and the other picture is taken from the internet. I don't know who cobbled them together. It's pretty much, we made it official right now. So the question now basically, what is the plan for legalization? It's been part of the electoral platform and promises. Where are we with implementation? So a few key considerations about that. First of all, we have little concrete details to date about how exactly it's going to go, how it will unfold. The federal government has appointed a legalization czar. This is my title for Bill Blair, benevolently. Basically appointed a parliamentary secretary who will oversee the legalization policy reform. Bill Blair, for the Canadians among you, of course, is the former police chief of Toronto. A law and order man who, however, is quite progressive, very well educated, understands drug issues quite well, go beyond mere police knowledge. So he's in charge of the implementation plan. There's been an announcement that there will be a federal task force that will sort out the details of how exactly things are going to unfold. There's a couple of key issues at the outset, and I'll mention a couple of other details. One of them is that in the Canadian system we have a strong divide in our system of federalism, very pronounced federalism, between federal and provincial jurisdictions. The key thing here is that in the Canadian context is that the drug control law is criminal law, therefore is controlled on the federal level. However, a lot of the relevant arenas for implementation of legalized cannabis, health, social, business regulation are provincial jurisdictions. And therefore the first basic question will be, what exactly will the federal level define in terms of implementation and how to do implementation versus delegate to the provinces for more decentralized implementation. The other important categorical point is that there's been a strong dominant emphasis on a public health approach with strict regulation in the Canadian context. Often that is further defined as something that will not be commercialization oriented. What that exactly, and often this is then distinguished also from what's been going on in the US. Of course, there's differences in the US models, but a lot of the definitions basically state that we don't necessarily want to go the Colorado route, where things are sort of heavily influenced by free market and commercialization interest. The Canadian model wants more of a public health approach, and that in many ways probably will mean much stricter regulation. This is also the tone that we're hearing from the federal government. The question is, of course, what exactly will that all mean, and how feasible is it? Also in reference to the fact that on a number of things, the genie is out of the bottle a little bit, or to a significant extent already. We have a medical marijuana industry, we have a medical marijuana framework, we have licensed producers for medical marijuana. So we're not thinking about implementation on bare or virginal grounds. A lot of things are already carved into the ground that will probably be quite difficult to revert or change significantly. So some of the key questions about implementation are who will actually, how will production be organized? Under the current medical marijuana regime, we have 30, at least that's what the Health Canada website is telling me, with 30 licensed producers for medical marijuana at this point. There will probably be more, so that obviously is an industry that has already proliferated and is in place. How will this industry be controlled in the short and in the long run? All these things are very open questions. And the big questions around dispensing. How will the, under legalization, marijuana be dispensed? What will the models look like? Again, the question is, will the feds dictate that, or just hand it to the provinces? Related or similar to the way we regulate our alcohol distribution under the government monopolies that we have in most provinces. What's been in discussion is to actually put marijuana dispensing under legalization into the liquor control systems, which is one option. There's divided views on that. We currently have the mailing systems for the medical marijuana dispensing from the producers, which may be retained. We have a number of community dispensaries where there's the possibility for those things to be legalized and sanctioned. This is what's going on in the municipality of Vancouver already at this point. And then there's discussion about home growing. So there's a lot of options that are being debated. It could be one of these things. It could be a mix of those things. All of this is open. We've opened questions about minimum age for use. There's no question that it will not be lower than the alcohol use restrictions, which are 18 and 19. The question is, of course, what will happen to the many cannabis users that are below that age. We have questions about how will product labeling, product regulation happening, pricing, taxation, things like impaired driving. All of these things are important open questions that need to be figured out for the implementation plan. Couple of other issues that I'll just quickly raise as questions. What will Canada do about the international treaties? Will it care, or will it start to renegotiate some of the solutions that have also been discussed here at this meeting in terms of revising or making reservations with its agreement to the treaties? The question of amnesty for the hundreds of thousands of people we have with convictions for simple cannabis possession. That's been a debate. How will law enforcement go about cannabis use, but also the existing dispensing in the communities that is currently really technically illegal in the years to come before implementation is finalized? And then obviously we need very good a systematic evaluation of the policy reform. This is an internationally significant experiment, the only national legalization experiment outside of Uruguay under a national scale. There's a lot of new data, systems, and indicators we need to put in place for a systematic evaluation. The only thing we don't have to worry about is we've assigned already the flag that will be official along with the picture of Justin Trudeau when things are finally in place. So we're pretty well prepared.
Thank you for that entertaining presentation. I'd also like to thank the organizers for Mark and others for having a Canadian panel. I'd like to thank John Walsh from Washington Office on Latin America for actually organizing the Canadian panel. So thank you, American brother. And now Brian Emerson's going to speak.
Thanks very much, Donald, and thanks, Benedict, for opening up. It's a public health physicians group in British Columbia, as well as the Canadian Public Health Association. I will spend a little bit of time talking about the provincial perspective. So, again, to sort of introduce or invoke the leader's statement, Justin Trudeau has kind of set the tone with a quote. He said, "It was never about a moneymaker, it was always about public health, public safety." And so I think that sets the tone for a direction in Canada. So I'm going to talk a little bit about what gets thrown a lot around. What is a public health approach? And then what would a public health approach to cannabis look like? And then some thoughts from the provincial perspective. So I kind of look at a public health approach as like if you look at it, three legs of a stool, which is a very solid object. You've got your policy directions, and we've got certainly, I quoted the high-level policy direction. You've got your strategies, public health strategies, and then critical, especially in this giant experiment that we're about to go into, is the evaluation component, the monitoring, the research, the public health surveillance, all those key elements. So under the policy direction, it's really important to get your principles and your objectives and your goals established. So we've got a few public health principles that I'd like to highlight here. One is proceed with great caution. The public health folks are a very cautious group, and so that drives a lot of what we do. Evidence-informed policymaking, critical. And in this area, unfortunately, we don't have a huge amount of evidence, which is where the evidence-informed or the evaluation can feed back into those evidence-informed decisions. Another principle is the notion of denormalization. We've had great success in tobacco with this concept of denormalization, but we need to qualify that, and it's without stigmatization. The notion is we don't want a normal alcohol, widely distributed product, but at the same time we don't want to persist with criminalizing and stigmatizing people who use cannabis. Individual empowerment and informed consent is a critical principle. Attention to social justice, equity, respect for human rights and freedoms. That principle really supports autonomy and self-determination, and also supports community development. Respect for traditional, spiritual, and therapeutic use, another key principle. Address the determinants of health. Public health very much focuses on the determinants of health and looking at what are the causes of ill health, as well as what are the causes of health and well-being are the key things to focus on. Protection against false claims and unsafe products. Individuals should be held responsible and accountable for actions that harm others. The people who develop problems don't receive the care that they need to deal with those problems. The other piece of the service issue is accessible services for people who are using for therapeutic purposes. Variations of substances that pose the least risk should be most accessible. Very much a principle of harm reduction. Adequate resourcing for the regulatory regime and adequate resourcing for public health measures. We heard this morning from Colorado that call that investing your systems ahead of time so that you can deal with the issues coming at you. And then really important principle, revenue generation should be a secondary consideration to promoting and protecting public health, which goes back to the overall policy direction of protection and promotion of public health. If revenue generation happens, that's okay, but that's secondary. So a public health goal needs to be established, and one up for discussion is is this notion of focusing. The goal should be public health promotion and protection, which means maximizing benefits as well as minimizing harms. And often, I mean, we hear a ton about the harms and minimizing the harms, but the maximizing benefits doesn't get talked about a lot. And public health is all about this balance. So that includes reducing inequities for families, individuals, and communities. So in terms of the objectives, which is another key piece of the public health approach, is looking at not only just health objectives, but objectives for all the sectors: the health sector, social services, public safety, justice, agriculture, environment, finance, and business. All these sectors are going to have objectives. And one of the challenges in this approach is going to be balance these competing objectives. But each of these objectives do need to be explicitly stated so that we can have a discussion about them. If they're not explicitly stated, then decisions are being made without full orientation. So some proposed health objectives would be prevent cannabis-related morbidity and mortality, and I certainly want to acknowledge Benedict's work in starting to try to estimate that. There's a lot of discussion about what is the public health impact. We need to start estimating that, and that work has begun. Minimize demand, prevent risky use, especially concurrent use with alcohol, and harmful routes of consumption, such as smoking. Delay onset of use by youth, enable health-promoting use by patients, ensure safe products, improve equity, and prevent stigmatization and discrimination. So there's some public proposed health objectives. I won't rattle off some possible public safety, justice, agriculture objectives, except to say that those need to be part of the discussion. And so what does a public health approach look in practice? And I'll move to the next slide. Okay. Yeah, I won't move to the next slide. All right, there we go. Not sure how well that, and I'm not going to go through all the bits and pieces of this, but basically I want to use this to talk about the strategies, which are the key elements in the circle. Health protection, health promotion, prevention, harm reduction, emergency preparedness and response, evaluation, monitoring and research, and services, both for people who develop problems as well as people who can use for therapeutic purposes. So Benedict mentioned a number of specific actions that can happen within this strategy framework. So I won't repeat those, certainly in the interest of time, but just maybe to highlight a couple to re-emphasize that are particularly important from a public health perspective. The whole idea of having a strong governance system is critical. And we've learned lessons from a whole range of endeavors that governance is absolutely critical to making things work well for people. You know, the whole idea of you could potentially establish a cannabis control commission. I think Uruguay has established the, I won't grab off the initials because I'll get it wrong, but really the whole idea being that this governing body structure, whatever it is, should have a clear mandate explicitly guided by public health goals and preferably stated in statute, because that's the way you enable persistence of the mandate going forward. And potentially consideration should be that it would operate at arm's length from government to allow it to have stability, clarity of focus, and provide some sort of insulation from industry influence that would pressure, that could be affected by pressures from revenue generation. The whole notion about supply management is critical, and the really important area from a public health perspective, and it's worth mentioning again, is the whole promotional aspect. In terms of lessons learned from tobacco and alcohol, that's been one of the most important lessons I've learned in looking at these issues, is that the harms have been hugely driven by the industry commercial promotion of these products. And we've certainly reined in the tobacco industry over 40 years. It's taken a long time. But the alcohol industry is going in the opposite direction, certainly in Canada, with regards to promotion. And so there's and the marketers and promoters have a huge range of different activities that they entertain. So this is an area that needs particularly strong focus. And at this point, I'd like to talk about a term that gets been used a lot at this conference, which is recreational marijuana. I mean, that is a promotional term itself. So I'm on a campaign to completely eliminate the term recreational marijuana. I mean, if you want to make a product attractive to youth, call it recreational. Like, all right. And so, you know, in fact, I think that the health and other policymakers have been co-opted by the industry in adopting this term. So if there's one message I'd like to leave for the conference is let's change the term. I notice Colorado is using the term, I think, adult use. I think non-medical use is another alternative, but let's just not buy into the promotional aspects and use the term recreational. That's critical. Am I doing that?
Yeah.
2 minutes, 3 minutes, great. So I think a couple other points I'd like to end up on is all of this needs to be worked into a vision. So you've got your policy direction, you've got your objectives, you've got your sense of strategies of what you want to do. But the next step is to take that and put it into a vision. Where do we want to go with this? Spend the time to develop that vision based on those fundamental directional elements, and then you've at least got a roadmap as to how you're going to get there, and you've got some criteria against which you can make your decisions about these various strategies. And then you can actually justify why are you picking one strategy over another. You've got your vision and you've got your supporting elements. So I think I'm about down to my last minute here. So just as I mentioned, a few comments from the provincial perspective. And Benedict mentioned that responsibility for public health and healthcare is shared between the federal and the provincial governments, of which there are 13 provincial and territorial governments. So a little bit of a challenge getting all these folks working together. But that shared relationship means that the provincial territorial governments are very interested in this topic. And the early message from the federal government is that they will be taking a collaborative approach. And this is really encouraging from the provincial and territorial governments. What it means to us is that we aren't one of a multitude of stakeholders. We're in fact partners in this, and that means joint decision making, which is something that we're quite encouraged. We're also encouraged that we won't be rushing this, and that we'll take the time to avoid the problems that we have to, so that we can not make a what was the term, a mess, a Canadian mess that's got to be cleaned up. So I'd like to conclude my remarks at this time to say that we're going to have to figure out how to make this happen in a way that provides some early wins, because going back to the Trudeau government, they're going to want to deliver this in the first 3 years, but exactly what, it's going to take a lot longer than 3 years, so how can we deliver some quick wins, keep the momentum going, because clearly from a public health perspective, we don't want to go back to the prohibitionist regime. So thanks very much. And I'm going to just skip the last slide, but get out of the way for Linda. And if there's time, I'll show this later. But there's where we're going with where we'd like to see this be.
Thank you, Brian. Who are those Canadian public health people throwing down the gauntlet to those people talking about recreational? Anyways, get used to it. I think Dr. Linda Valdez is now going to do her presentation.
Thanks, Donald, and thanks for the invitation to present. I'm going to take a bit of a different tact. I'm actually going to present from the patient's perspective. that are within the medical cannabis programs in Canada, reflecting on some of our past data and some of our current data, and then have a bit of a reflection at the end where I don't have any clear answers, but just putting out some questions of how legalization in Canada may potentially impact people that are using it for therapeutic purposes. Oh, you made it really fancy, Brian.
That's Donald did that.
Going backwards.
Oh.
Keep going, keep going, keep going. Keep going.
There we go. And I do want to acknowledge that I'm sharing this presentation with my colleague, Rial Catwick. Give a little wave, Rial, who's in the audience. If you have any questions about the canary study, she's the person to turn to. I do have some disclosures, and they're mainly related to Rial's training program at the University of British Columbia. We have a program that sponsors, through the university, partnerships with industry and nonprofits called the MyTax program. And we were fortunate to receive funding for Rial's program through the Canadian Association of Medical Cannabis Dispensaries, the Canadian Consortium of Investigation of Cannabinoids, and AFRIA, which is one of the licensed producers in Canada. So this is an amazing partnership between research, a nonprofit group, as well as industry. So we really feel that we have everyone represented, so hopefully we'll come across as being unbiased. So I want to give a little bit of context, and I think Benedict and Brian already kind of alluded to some of these programs, but just for those of you that aren't familiar with what has happened in Canada, let's look back. And back in 2001, we had the MMAR, which was regulation that really came from this real push that came from the community, from patients, saying that they wanted to have a regulated medical system in Canada. And there was three main sources of medical cannabis within that system. There was personal production, where people were allowed to grow a certain number of plants for themselves for medical purposes. For those people, particularly those that were on disability and were unable to grow or were in living situations where they really couldn't start a little grow up in their basement or in a spare bedroom, they had people that were designated growers who could grow for more than one individual that had a license. We also had, wow, really sensitive. We also had a federal producer, Prairie Plants, which is now actually shifted into being a licensed producer in Canada. They were growing cannabis in a mine in Flin Flon, Manitoba, which is my home province. In order to access this program, though, you had to get authorization from Health Canada. We had up to about 25 or 30 pages that physicians had to complete, which anyone that is a healthcare provider can know that physicians aren't too pleased to fill out documentation forms. So it was a real barrier. There was also quite a restricted list of health conditions that people could apply to the medical program with. And with some of those conditions, they actually needed a specialist to approve their conditions. And it had to be conditions that weren't responsive to conventional treatment. By the end of the program in 2013, we had just under 40,000 Canadians that were approved under the MMAR. And I just want to put that in context. We had guesstimates based on population data of about 1 million Canadians were using cannabis for therapeutic purposes. So only kind of a drop in the bucket were being represented in this program. We did a study called the hemp study, which Rial was also part of, that really was looking at the patient's experience of accessing cannabis and the perceptions of the health effects in using medical cannabis. And these are just some of the key points from that study. One is that we saw gatekeeping behaviors by many of the MDs or the physicians that patients were trying to access cannabis through. They were either refused to have the authorization provided, or there was significant delay up to over a year of physicians being willing to sign people's authorization. We also had patients reporting significant stigma and labeling attached to their medical cannabis use. And I'll never forget one HIV/AIDS patient who was nearing the end of life who said, you know, I'm on 28 different medications, I'm down to 100 pounds, my skin and my hair is falling out, and my doctor is trying to convince me that I need addiction services because I've requested an authorization for medical cannabis. And what was really happening is that we were seeing a marginalization of people that were already marginalized and underserved in our populations. People that were living in disability, people that had stigmatized health conditions, were almost feeling like they were being additionally stigmatized attached to this. We also saw that because of the struggles that people were having in accessing the system, they were moving to secondary sources. So they were either going to community-based dispensaries, which are an illegal source of cannabis, or some people were commenting that they had to go to street sources. And what was really interesting is that people said despite some of the social risks, the criminal risks, and some of the health risks attached from accessing cannabis from these sources, they still saw the health benefits of using medical cannabis to outweigh this. Now, flip ahead to 2013, where we've had numerous constitutional challenges to the MMAR that resulted in Health Canada having to develop new regulations, the MMPR. And the main purpose of the MMPRs is really trying to maintain reasonable access to medical marijuana. Yes, it's marijuana with an H. We're not quite sure why Health Canada won't change that. And I've been very happy to see that cannabis is being predominantly used in this meeting. But the idea is that the MMPR is supposed to maintain reasonable access while addressing safety and security risks. The definition of reasonable, though, has not been clearly made. What is reasonable access? How does reasonable access differ if you're living in an urban region where you have access to specialists and physicians, or if you're living in a remote rural region where you may have access to one family doctor or no family doctor? In terms of the source under the MMPR, we have licensed producers. We had over 600 applicants to Health Canada, and we're now, as Benedict mentioned, we're up to 30, and there's a sense that there's more under the new government being ready to be approved. These are people that can grow medical cannabis or have access to medical cannabis, and they're giving it to the patients through a mailed courier service. So they're using Canada Post. I don't know if they're using other courier services as well. I'm seeing some nods, yes. Which has been a bit of an issue. We had a few people in our qualitative studies say, you know, when you live in a rural region where you have one postmistress who gets the Canada Post packages, it kind of has an issue around your anonymity of using medical cannabis when this package arrives, you know, once a month. So I think we need to be aware of those issues from a patient's perspective. There was a little bit of shift in terms of access under the MMPR. The documentation went from 28 pages down to about 2 or 3 pages. They also included nurse practitioners, which are providers of primary care in Canada, to also sign off on the authorization. The issue has been provincially, we have yet to have any of the nursing associations allow nurses within their scope of practice to actually sign the authorizations. They have kept a restricted monthly amount for patients. They can only have a maximum of 150 grams a month of dried medical cannabis. What's really important here is that it shifted authorization from Health Canada to physicians and healthcare providers, which I think is a really important point because it really places responsibility onto the healthcare provider, which we've now seen them responding to in terms of even more hesitation about taking on that role. To date, we have about 48,000 Canadians that have registered under the MMPR, and that's from Health Canada data that just came last week. We gotta stop the process here for a moment. There's been numerous court injunctions related to the MMPR, and we just recently had a decision in February related to it. So the MMPR was challenged under this issue of reasonable access and really about the affordability of medical cannabis under this new regulated system being offered by the LPs. And the injunction really allowed people that still had authorization under the old regulations, the MMAR, that were either able to produce on their own or to have a designated grower to continue to do so until there was a court decision. The difficulty was that we already had some people that had to throw out their cannabis plants because they were getting ready for this shift in regulation. So we had some people scrambling that actually didn't have access to their plants and their source anymore. But the decision was made in February, and it was seen as infringing upon people's constitutional rights, particularly related to the issue of affordability. And the Canadian government was given 6 months to either create a new or a parallel medical marijuana regime. Also, as an aside, there was another court challenge related to the fact that only dried cannabis was available, and they've now shifted it so that you can possess derivatives, specifically oils and fresh buds and leaves. So Rial has been leading a study called the Canary Study, which is really the canary in the coal mine, where we're trying to get an early kind of sense of how the MMPR is functioning. We had just under 400 Canadians across the country take part. We had people that were under the MMAR, people that were licensed under the MMPR, as well as people that were outside of that system and were probably either getting it from their own self-production illegally or going through the medical dispensaries. Most people were either reporting health conditions related to pain, arthritis, or mental health. And the reasons that they were using it were for pain relief, for sleep, for mental health issues, overall well-being, as well as nausea and vomiting. And obviously we had people that were using it for a multitude of purposes. So under the MMPR, what it really is revealing is that we had almost 3/4 of the sample were still using illegal sources. Just under 50% of the MMPR, and just over 50% of people that were still under the MMAR. And I think this really relates to the fact that half the sample still reported difficulties in accessing cannabis for therapeutic purposes. And most notably with the new group that are licensed under the new regulations, cost was an issue, availability was an issue, and then the registration wait time. And if you're living with a health condition like stage 4 breast cancer, and you're being told that you're going to have to wait for a bit, or your doctor wants to wait 6 months before they use it, you may be dead by then. And I just want to really pull out this idea of affordability. If you look closely at this, the designated producers is second from last in terms of the actual affordability for people trying to access medical cannabis through the legal system. And the most affordable was being either self-produced or having a designated producer or having personal production. A few other kind of key points is that the group that was accessing it through designated growers or from self-productions were most satisfied with their legal source compared to the MMPR group. And again, this was very early stages. This was just kind of 6 to 8 months after the regulations came in, and the LPs were still working out a lot of, I think, their speed bumps. You know, in terms of legal sources, people said that they felt they had better quality of care, that they had more expertise and support in terms of using medical cannabis, and they preferred the way it was being administered. And I think that reflects the well-established services that many of the licensed or the community-based dispensaries had established that people were accessing their cannabis from. But what's really interesting, though, is each group did express a future intention of being part of the MMPR, and I think that's really because people want to have that license so that they can show that they are licensed in Canada and can legally hold cannabis for their health conditions. And not surprisingly, people in the MMPR, despite the speed bumps that they were experiencing, still said, I really want the LP to be my source of cannabis. I really think it's going to be the best way that it's provided. So some really quick reflections, because I'm running out of time here. So yes, there's been some issues around access, availability, and satisfaction with the product and services under the new regulations, and we still see affordability and gatekeeping by MDs as creating access issues for patients. We really do need longitudinal research. This is just a first cross-sectional look. We need to be seeing what's happening a year later, what's happening in 2 years as the medical program continues to develop and the LPs are able to evolve. We also, despite these access issues, people want to be legally approved to be using cannabis within Canada. Just a very quick, what lies ahead. The federal health minister has indicated that she has no intention of appealing the court decision, so they have 5 months now to try to sort this all out and create a new system. She acknowledges that accessibility and affordability are key issues that the MMPR is not currently addressing. And some of the possible options that we're seeing brewing out in social media and within research and policy sectors is maybe we need to reinstate personal and designated production. We need to create better and easier authorization processes. There's still this issue of insurance coverage. We don't see it covered under our provincial health insurance policies. And now the pharmacists have decided after 10 years of saying we want nothing to do with this, they're saying we're the only place that medical cannabis should be distributed from. So I think they've seen some dollar signs and they're really interested to get on board. So some key things that we need to think about. Will legalization increase the sources of medical cannabis in Canada or not? And I think we really need to think about that if the pharmacists jump on board here, all of a sudden, if they get the distributing rights, it's going to limit access because the costs are going to be associated with the distribution fees. It's also going to make things really hard for people that are in rural and remote regions. In terms of costs, I did some calculations here. I've heard numbers saying that we're seeing some of the medical cannabis, the costs in like Colorado and Washington going down to like $7 a gram. You know, our poverty level in Canada is 21,000. If someone is using 3 grams a day for a health condition times $7, almost 40% of their income is going to go towards just medical cannabis. And that's typically just one medicine that they're using for their health condition. In terms of the quality and type of cannabis, I have concerns that if legalization comes in, we're going to see an overemphasis on strains that are really high THC, and we're not going to see the same emphasis on the CBDs, which we know are going to be useful in terms of seizure disorders. We also are seeing more cancer research suggest that there may be a role. So I think we need to be cautious. We're already having some patients tell us that the types of strains that they had access to at the beginning of the LP development, some of those strains are no longer available. As the new government has come in, LPs are focusing their attention on the high THC strains. However, legalization may result in boutique and heritage growers coming forward. Very lastly, I'm worried about stigmatization. While legalization may normalize cannabis use, it may also increase attention to some of the social costs and the public health issues attached to using it for recreational purposes. And as a consequence, will this make doctors less hesitant to actually talk about it in a medicinal context? And could it muddy the water of medicinal use? I also worry that if patients start moving towards the recreational market in using medical cannabis, are they going to be getting the education, support, and follow-up care from their physician who may not be aware of their use of cannabis for therapeutic purposes? And as a researcher, am I going to see the very, very, very limited dollars towards medical cannabis research being diverted towards mainly public health impacts of using recreational cannabis, and we're going to see less focus on the therapeutic values of this plant? Sorry, I know I'm a little bit over, but thank you very much.
Morning. Benedict started with some comments about American attitude towards Canada. I should say I think that attitudes towards Canada serve as a kind of litmus test in American politics. When we all agree about the facts. They have health insurance and they don't have guns. And if you're a Democrat, you say they have health insurance and they don't kill each other. And if you're a Republican, you say socialized medicine and they're unprotected. I'm in the first camp, this is the most important event in the sort of marijuana policy agenda since Colorado. And Canada is a rich nation which is likely to carry out this as competently as we might expect on average amongst rich countries. I just recently learned that the Chinese government likes to talk about its public policy as being correct, beneficial, and rational. And I sort of think that that's a lovely trio of adjectives to attack maybe Canadian marijuana policy. Certainly, you know, it is avoiding the trap of creating a profit industry. I would say what I'm sure is said at least every time slot, not literally in every session here, and avoiding the problems of irreversibility that comes with establishing a commercial sector. And they seem to have avoided the nonsense of regulating like alcohol. I do think that the approach is overly sober, which you might expect of Canada. No recognition, I think, of why people actually use marijuana. Question is just, does pleasure count? But mostly what I have to say is nothing but is basically possible. I don't want to go through all of these things, but just sort of contrast that with what is happening in this country. Because they're planning, well, I mean, Colorado and Washington really did invest in planning, at least, you know, a 12-month process. I don't think they said, but I don't think they did well at articulating the goals, really developing an evaluation process and building it into it. There's some not good. Coordinating federal and provincial government hardly, and not paying, could not say we paid attention to experiences of regulating alcohol and tobacco, which I think are all characteristics of the lady. I looked at the CAMH report that Benedict was the principal author, and I should start by noting that though it was published before we finished the Rand group finished the Vermont report, we, of course, having searched solution, never thought to look north. There's no mention of it there. It really reflects our provincialism. It's sort of offensive given that we were doing it for Vermont, you could say.
At least for Vermont, you could.
And you know, it advocates for a state monopoly. I think I've added inefficiency. We want an inefficient producer of cannabis, and state monopoly is almost guaranteed to do that. In contrast to Linda, I think one of the real attractions is that as we learn more about what makes cannabis harmful, the monopoly producer can alter the varieties that are available to provide more healthy cannabis and avoid the most unhealthy. So far we only know about THC and CBD, and maybe that the monopolist establishes a floor for THC-CBD ratio that could go beyond that. The KLH report is, as you would expect from an institution connected to a hospital, it's a real public health report, and take a jab at that. I mean, not everything is health, just almost everything. And I think that it sort of strains at notions of equity and harm to try to put them all in the public health model. That's not a very to make up of the roads. And all I want to do is point you to the government monopoly line. You see that it does well by almost all the criteria that we use for judging an alternative regime. So, if all you can cite the Rand study as further support, this looks like a very plausible approach. But what's missing? So, here, I'm doing this from CAMH, the overarching purpose should be health promotion and health protection. This means maximizing benefits and minimize harms, promoting health and wellness, and reducing inequities for individuals, families, communities, and society. Benefits. And as far as I can tell, I think I did a full search. I think that's the only mention of benefits. They never specify. Well, if you were talking about alcohol, we think we understand the benefits of alcohol, and they're important in the way we make decisions. If cannabis is like tobacco, then we wouldn't talk about benefits. Then indeed, what we're doing is trying to avoid the known adverse consequences of prohibition while trying to figure out how to minimize consumption. Because we think that the pleasure is all, that there is little pleasure actually associated with cigarette smoking, cannabis. And John Corkin's analysis of the extent to which cannabis use in the US is now dominated by daily or near daily users, many of whom have diagnosed problems, suggests that maybe it's more like cigarettes. And indeed, my critique is wrong, we should not legitimate the pleasures that come from cannabis. But I think that is a crucial issue to decide. Do we distinguish the pleasures of the altered state provided by a nice mellow and a good, actually don't know the name of it. Some form of cannabis. I think that is Thank you very much.